So Maureen, I think we'll go ahead and get started if that's okay with you.
Sounds great to me.
And I just turned on the recording feature because we like to have these archived for folks who aren't able to join us today. But
Wonderful.
We've got a great group on. It's nice to see some familiar names and some new folks who are joining for the first time. We're just so pleased to have Maureen Muller-Arty present this information. I'm Brenda with the Wyoming Primary Care Association in Cheyenne, and this is the third of a series of 4 modules that we have been presenting on diabetes for healthcare providers across the state of Wyoming, and we're pleased to do this one today, and this one is on nutrition for diabetes and hypertension. And before we get started, though, let me just give you a little information about our presenter, Maureen. She's a registered dietitian, and she has been working in diabetes since about 2005. She enjoys working with clients and helping them to identify ways to live healthier, more fulfilling lives. She believes that nutrition is the foundation for building and maintaining a healthy lifestyle. Maureen, I need you to come live at my house. Has a doctorate in mind and body medicine with an interest in health and wellness coaching. And with all of that, she enjoys working with people with diabetes and healthcare providers to improve the health of the people of Wyoming. So I don't think we can have anyone more knowledgeable and skilled to do this presentation for us. A couple things before we get going. There will be some evaluations at the end. Marina sent one earlier that if you're on the call today and you're interested in the continuing education that this qualifies for, fill out that evaluation and send it back to Maureen. And also we'll send you a survey, a short one that just gives us a little bit of feedback on this presentation and then our educational offerings as we move forward. And Maureen, I think I've covered everything. If there's anything else that we need, you go ahead and just cover it.
Okay, great. Well, welcome everyone. Usually I can see some faces, but today I can't. So I'm just going to move on because like I keep saying, I keep learning something new with technology every day. So this is a presentation that's kind of near and dear to my heart. It's nutrition for diabetes and hypertension. So let's just jump right in. Okay, here we go. So this program is sponsored by the Wyoming Department of Health, and I always like to mention that, and I made a mistake on this slide. Excuse me, I'm sorry about that. The program manager is actually Hannah Harold, not Catherine Southard. My apologies. It must have been an old slide. And this presentation, I don't have any disclosures or financial interests to tell of. And this will be available for 1 continuing education unit. So as Brenda said, you just email me your evaluation and I'll email you back a certificate. So I have 3 main objectives for today's program. I'm going to review basic nutrition for diabetes and hypertension. I'm going to identify elements of the DASH diet. And I'm going to talk a little bit about SMART goals and some of the elements of SMART goal planning and how to use those with clients. And I'm really excited about that because I really love and utilize SMART goals quite a bit myself. So preventing and managing diabetes. Let me take this off of there. Oops. Not sure what I just did. Okay. Begins with nutrition. I always think about the nutrition as the foundation of part of that balancing act. So we have nutrition, activity, and maybe nutrition and activity go hand in hand. Then we're also managing stress, but nobody has any stress, right? That was probably an understatement. And then we're also managing medications as well. So those are kind of some of the elements that we talk about when we're talking about preventing and managing diabetes and hypertension. So with most programs, we always start off with a diabetes prevention program. And I know that many of you are already aware of this program, but the reason that that I always start off with this is because we've learned so much amazing information from this research study. And one of the things that we found is that lifestyle intervention reduced the incidence of type 2 diabetes by 58%. And I think we can all just go, wow, that's an amazing number, 58%. But what's even more impressive about that is that the goal of the diabetes prevention program was a 7% reduction in baseline body weight through a low-calorie, low-fat diet, and greater than 150 minutes of moderate intensity exercise per week. So the reason that I'm stressing that is because I feel like those are really achievable goals for most people. And I just always like to really, really highlight that. And also the metformin group in that program also had a 31% reduction in developing type 2 diabetes. And metformin is a medication that's been around for a really long time, and it's also inexpensive. It's a generic, and I think it can be bought for less than, I'm going to say less than $10 per month, but nurses will know that better than I will. So the other part of the diabetes prevention program that I wanted to just really talk about too, and is that there was a mean follow-up of 15 years. And that follow-up was really interesting. Number one, that it provided us the longitudinal data of this big program, of this big study. And they found that the lifestyle intervention group continued to have a 27% reduction in diabetes incidence, and the metformin group another 18%. And again, these are really impressive numbers. But some of the things that I also wanted to highlight from that mean follow-up of 15 years was the participants that did not develop diabetes had a lower prevalence of microvascular complication than those that did. And basically, if you want to read through the study, I think it's definitely worth it, and it's because it's pretty inspiring. But the results also support the importance of diabetes prevention. So we all kind of know how diabetes happens, and I sometimes find myself doing, simple drawings like this when I'm working with clients, because I think that can really help illustrate how diabetes happens, and we all learn in different ways. So, whether we're using a visual or a pamphlet, sometimes simple drawings really kind of drive the understanding home of what diabetes is. And basically what this is showing us is that as we eat food, specifically carbohydrates, they're digested to glucose. Glucose has to get from the bloodstream and into the cells. And the key for making that system work effortlessly, or fluidly is probably a better word, is insulin. And insulin is actually kind of allowing that cell to be permeable to the glucose in the blood. And so that's just a quick review. I'm going to spend a little bit of time talking about blood pressure categories, because the new American Heart Association guidelines for blood pressure categories was released less than 2 weeks ago, I think. And there's been a lot of talk about this, because the new guidelines are showing that anything above 120/80 is considered high blood pressure. And so the lifestyle interventions that I'll be talking about through this talk will actually support blood pressure, managing blood pressure as well. One thing I wanted to talk about with the new blood pressure categories, and I spent some time reading the report and looking at all of the information, and a couple things I really wanted to highlight. This is the first update since 2003. I thought that was really interesting. And because of this update, about 14% more Americans will be diagnosed with high blood pressure. But the reason that I really wanted to bring this up is because the focus of these new blood pressure guidelines is really on lifestyle modification. And that's where I think, we as professionals are really shine in our ability to help people making lifestyle modifications, especially with things like working on diabetes prevention programs and working in diabetes self-management programs. And they're really calling for more team-based care with these, when they release these categories as well. The other thing that I liked about this, that I found interesting, not that I liked or didn't like it about this, about the data, was that they were really specific about the types of diets or the types of intervention that constitute a healthy lifestyle. And one of the things that they promoted was the DASH diet. And so that's something that we've also been working to increase awareness of and increase adoption of as well. And the DASH diet is really a simple diet. It's basically fruits, vegetables, non-fat or low-fat, non-fat dairy. I think I said that a little confusing, but lower non-fat dairy, whole grains, less than 1,500 milligrams of sodium intake. And there's also that's for people with diabetes, limiting alcohol to 2 drinks a day for men and 1 drink a day for women, and exercising at least 30 minutes 3 times per week. So team-based care, and I read this and I just thought that this was a really great slide, and this is from David O'Barb, and I apologize that it's a little bit wordy, and I don't usually like to put that many words on a slide, but this is something that you can take, that you can look at again. And again, this is the American Medical Association. I'm not sure if he's the director or he's part of the task force, but basically he was, encouraging patients to work with their physicians and create a treatment plan that focuses on a healthy lifestyle changes, such as exercising, eating healthy diet, reducing salt intake, drinking alcohol in moderation, losing weight if overweight, and using antihypertensive medication when needed. And to me, this really screamed like, oh my gosh, we need to really build our team-based care to accomplish all of these goals and work alongside our physicians and healthcare providers. So I'm going to just talk a little bit about some tools for managing and preventing diabetes and hypertension. So one of the tools that I really like is the plate method. There are a lot of different types of plate methods available. This is the choosemyplate.gov. And you can this is a really interactive website where you can actually go in and make, and really individualize it to your patient's needs. So I encourage you to check that out. I also wanted to talk about added sugar. This is probably one of the questions, I get a lot of questions about added sugar, mainly like, what does that mean? And so I'll show you in a couple slides the new label, the new nutrition facts label, but basically I wanted to just reiterate that added sugar does not refer to the sugars or carbohydrates in fresh fruits, vegetables, and milk. This added sugar is sugar that's added during processing. So, think about, breakfast cereal is an easy one to pick on, I guess, for lack of a better description, because, there's a lot of sugar added to some, not all breakfast cereals, during process. So this is what added sugar is talking about. There's benefits from reducing daily intake to 10% of total energy intake. But as we all know, that different organizations have different recommendations. And I thought it was really interesting that the World Health Organization recognized that a 5% reduction, or about 25 grams of added sugar per day, would actually provide additional health benefits. But that's a pretty strict reduction and probably not achievable for many. But I just thought I would kind of show you that because 10% is a great goal, but that there was some data that represented that a 5% reduction had even additional health benefits. Less than 10% reduction in sugar actually reduces the risk of overweight, obesity, and tooth decay. This is something that we should think about for our kids and maybe even adults as well. 1 teaspoon of sugar is equal to about 4 grams of carbohydrates. Okay, let's look at the labels. So this is the old nutrition fact label, and this is the new one that's going to be, oh gosh, I forgot. I think 2018, by summer of 2018, this is going to be mandatory. But I apologize, I don't have the exact date of that. So I wanted to point out a couple of things on here, and these are really great tools that you can talk with your clients about. The serving size is going to be in bolder type, which is wonderful because then you can actually see what the serving size is. And the serving sizes are also going to be updated. And so they're going to be more reasonable portions. And I think that that's a really beneficial change. Let's see. So there's new updated daily values. There's the new added sugar. That's the reason that I really wanted to show you this, because you can see on this slide that it includes added sugars. And that's the really important thing about the new label. What else? There's a change in the nutrients required. So now there's going to be vitamin D, calcium, iron, and potassium. And I think most of us in Wyoming are pretty aware that our vitamin D levels in the winter, probably from November to April, are pretty low. And so that's something that we could focus on. And in my experience, many health fairs are offering vitamin D tests so people can actually assess where they are on vitamin D. I'm going to jump in and talk a little bit about fiber. So we have different types of fiber. We have soluble fiber, and this is the pulp in food. These are things that attract water and slow digestion. So those are things like oat bran, barley, nuts, seeds, beans, lentils, peas, some fruits and vegetables. And we also have insoluble fiber. So that adds bulk to stool, helps food pass through the stomach and intestines more quickly. I always like to think of insoluble fiber as the little street sweepers. You know, they're really cleaning out your intestinal tract. And those are things like wheat bran, vegetables, and whole grains. So as a dietitian, when I look at these types of foods, these types of fiber, I always think about these as foods that I would add into a meal. So for example, if I was making, I don't know, meatloaf or something, you could sneak in some, or not even sneak, I don't like to say sneak, but you could add in some lentils or add in some vegetables or add in some oat bran to really boost up the nutrition. And that's also something that I've been focusing on as a clinician, is not so much talking about how to, what foods we need to get rid of, but what foods that we can actually bring into the diet to support healthy living and to support our bodies. And so that's one of the ways that I like to think about fiber, and I hope you find that helpful. Sodium, we get a lot of questions about sodium, so I'm hoping to kind of give some of the more general guidelines. So the general guideline is less than 2,300 milligrams per day and less than 1,500 milligrams per day per the DASH diet and for some people. So people that are at risk for hypertension or people that have type 2 diabetes. So let's look at some of the foods that are high in sodiums. As I was preparing for this talk, I had listed on there ethnic foods, and I thought, okay, well, sure, ethnic foods are definitely, or sometimes, not definitely, are sometimes higher in sodium. And I had, Chinese food, Japanese food, Vietnamese food, Indian, and then I thought, how about American food? If we think about, a burger and fries, those are also, there can be more than 1,000 milligrams of sodium in a serving in a dinner of a cheeseburger and fries. Also things like cured meats, ham and bacon. And just reminding people of those, that there is a lot of sodium. And, as far as strategies for those types of things too, just remembering that, again, this is just my personal, this is the way that I like to work with people is, they may not have to eliminate bacon because I think for some people that's not going to happen. But just reminding them that it is a high sodium food and maybe just limiting the quantity. And that's something that we can really work on. Foods like corned beef, soy sauce, some frozen foods are going to be higher in sodium, but some are not. So really just remembering to look at the ingredients. When I buy something in, just anything in general, the first thing I actually look at is the ingredients. I want to see what's in this jar or can or box of food that I'm buying. And, I think that reading the ingredients can really tell you a lot about it. Peanut butter is a perfect example. When I buy peanut butter, I want the ingredients to say peanuts. That's it. That's all I want. Okay, more about sodium. So if you need it, as I was putting together this talk, I sometimes get sucked into the rabbit hole of research, and I found this really great article about sodium, and it was more about more reasons to really pay attention to sodium. So for every sodium So table salt is sodium chloride, so it's about 40% sodium. So there's about 2.5 grams of salt consumed for every 1 gram of sodium. That's not the really important point. The important part of this study was that excess sodium was linked to the development of type 2 diabetes and also to LADA, which many of you know about, latent autoimmune diabetes in adults. And I thought that was really compelling. And there's also some previous research that suggested that excessive salt consumption may increase the risk for type 2 diabetes. As I thought about this and I was reading the research, I wondered if that, excess salt that people were getting if that was really in the form of more fast foods or the quality of foods. And I think that it may be, but I have to pull that out and really, really look at some of the data of that. But, when I think about somebody that's eating a diet high in sodium, often, not always, but often it's reflective of a highly processed or, a fast food style type of diet. And so some of the ways that the excess salt increases the risk for type 2 diabetes is through a direct effect on insulin resistance and or by promoting high blood pressure or weight gain. And at the conclusion of the study, this was the last part that I read. It said, we confirm an association between sodium intake and type 2 diabetes, and that high sodium intake may be a risk factor for LADA, especially in carriers of high-risk HLA genotypes. This suggests that these findings may have an important implication on the primary prevention of diabetes with adult onset. So basically just another reminder of why it's important to talk about salts with our clients and really help them understand where to look on the labels to understand how much sodium is in a food, and really working with clients to assess their diets. Okay, I'm going to see if there's any questions before I keep going on. Anybody have any questions, or should I just continue? Okay, I'm gonna keep continuing. Oh no, sorry about that. Okay, back up to physical activity. Okay, physical activity. Well, I think that I wanted to talk a couple of things. I'm just going to reiterate something about the diabetes prevention program, was that they found that 150 minutes per week of moderate intensity activity exercise was really associated with reducing diabetes incidence. That's not a lot of activity. That's about 20 minutes per day, and that's really why I wanted to bring that up. So there are a lot of different exercise recommendations from different organizations, and I wanted to really summarize them here. So adults with type 1 and type 2 diabetes, again, shooting for greater than or equal to 150 minutes of moderate intensity physical activity per week over at least 3 days per week, with no more than 2 consecutive days without activity. Shorter durations or shorter durations of vigorous intensity of activity. So interval training, bike riding, you could do, any kind of vigorous intensity interval training with anything. You could even do it with walking. I also read recently, I think it was this week, that I think it was interval training was really helpful for delaying cognitive decline. So stay tuned for more information on that. But I thought that actually gave me a little pep talk personally to get out there and do some more vigorous intensity activity. The recommendations also include 2 to 3 days of resistance exercise on days that people are not doing moderate intensity vigorous activity. And basically the goal is to decrease daily sedentary behavior. And that's why I highlighted that, because if we think about it, decreasing sedentary behavior, then, even if it's getting up from your office and getting a glass of water every 30 minutes or so, that's something that most people can do. Flexibility training and balance training about 2 to 3 times per week, especially for older adults with diabetes. And I really wanted to stress the balance training there, and you know, being a group of healthcare providers, I think we've all probably seen that how, you know, losing balance and flexibility can be really lead to a decrease in quality of life for so many people. Yoga and Tai Chi are appropriate for developing flexibility and balance. Okay. So I'm going to turn this over a little bit and talk about exercise with specific long-term complications of diabetes. So I wanted to, you know, these are things that are, you know, sometimes people with diabetes have retinopathy. So how do we, you know, what do we need to do? You know, these are really more safety minded. So retinopathy, of course, is if it's proliferative diabetic retinopathy or severe non-proliferative, oh my gosh, I can't say that word, is present, vigorous intensity aerobic activity or resistance exercise may be contraindicated. And so there's a risk for triggering a vitreous hemorrhage or retinal detachment. And so this is where that team-based care really comes into play. So make sure there's a consultation with an ophthalmologist prior to suggesting activity. So peripheral neuropathy. So this happens when there's a decreased pain sensation or a higher pain threshold in extremities. So think hands and feet. There's also an increased risk of skin breakdown with peripheral neuropathy, and infection, Charcot joint destruction with some forms of exercise. So these are when somebody has peripheral neuropathy, we should be doing assessments to make sure that the exercise recommendations are appropriate. But the good news is, and I love this, that the studies revealed that moderate activity actually improves outcomes of peripheral neuropathy. So one of the things that we can make sure that we're asking people about is if they're wearing proper shoes and if we're doing foot exams. So just a simple foot exam can be a really great way, you know, kind of a way to talk about exercise and make sure that somebody is appropriate, and also, you know, for getting help when we need it. Autonomic neuropathy. So this is something that, you know, if somebody has autonomic neuropathy, they're also at risk for a lot of different types of adverse events. So, you know, postural hypotension, difficult with temperature regulation, impaired night vision. So a lot of different things. And you know, people may also be more susceptible to hypoglycemia. Cardiovascular autonomic neuropathy is also an independent risk factor for cardiovascular death and silent myocardial ischemia. So anybody that has autonomic neuropathy should undergo a cardiac investigation before beginning physical activity. So there again, you know, this is where that team-based care comes into play, but it really relies on us being able to identify that, okay, this person has autonomic neuropathy, we probably need to send them back to their physician and maybe have them cleared for exercise. Diabetic kidney disease. So physical activity can actually acutely increase urinary albumin excretion. But, and I actually found this really interesting and encouraging, that there's no evidence that vigorous intensity exercise increases the rate of progression of diabetic kidney disease. So basically, there's no need for specific exercise restrictions for people with diabetic kidney disease. And I thought that was really exciting. And these are all documented in the 2017 standards of care if you need a reference. And I'm sorry I don't have it on these slides. So I always like to talk about practical tips, practical physical activity tips. Want to make it fun. Do something that you love, whether it's walking outside or, I don't know, doing Zumba or an exercise class, whatever, but make it fun. And maybe, you know, maybe part of our job is to actually help us when we're working with our clients identify what it is that they like to do that is fun. Exercise with friends. One of the things I read a study several years ago about how when women are exercising together, you know, whether they're going out for a long walk or or doing something, activity wise, that they're secreting oxytocin. And you remember what oxytocin is? It's that bonding hormone, so that it actually increases bonding between friends. And I thought that was a really great reason to continue to do physical activity. And the more often the better. Breaking it up is also a wonderful way to get in enough activity per week. So, a 10-minute walk in the morning and a 10-minute walk in the evening, or however people can fit that into their lives. We have unlimited there's unlimited ideas for the types of exercise. So walk, ride a bike, swim, do chair exercises, dance, the list goes on. But that's when it's our job, that it becomes our job to really talk to our clients and know them and learn what they like to do. So a couple of healthy activity behavior tips: increase slowly, just minutes can make a difference. If you have someone that hasn't exercised in a long time, maybe starting off with 1 5-minute walk per day is an appropriate goal. Again, we have to move our muscles. We know that muscles in action are actually eating up that glucose, and so that can actually help glucose levels drop. Exercise can also be done in chairs. We're going to have a wide range of people in what they're able to do, actually. So kind of just being sensitive to that. Some people might like to walk, but some people may be limited in the type of exercise that they can do. So we want to find things that they can do for each person. And and the other tip is just to set aside time every day just for you. And basically, we're transforming unhealthy behaviors to healthy behaviors. And this, I think that this is a pretty appropriate slide. We have, sitting at our desks, hopefully not too much smoking. I think smoking is declining. Fast foods, a lot of sedentary time. Again, remembering that, I've heard it said that, sitting is the new smoking. Alcohol, moderating alcohol, and sleep. So we really want to transform these unhealthy habits and behaviors to healthy habits. So I'm going to switch my focus here and talk a little bit about motivational interviewing. And this is really just an introductory slide to motivational interviewing, but I think this is a really wonderful way of connecting with our clients. And I'm bringing this up also because many of us in Wyoming have attended the Diabetes Prevention Program Lifestyle Coach Training in the past couple of months. And coach training really begins with motivational interviewing. And so I just thought I would go through a couple of essential pieces of coaching and or motivational interviewing. So it's really a collaborative, patient-centered approach. We're working with patients to connect their behavior with something that they care about. And, this is taking us out of the equation and figuring out what the patient wants. So motivational interviewing, a good motivational interviewing begins with asking open-ended question. And also I think it begins with setting aside our own preconceived ideas of what is a good exercise or what is a good diet. It's really trying to, work with where the patient's at that point in time. Tell me what you like to do for exercise, or tell me about your daily meals. Do you like to cook, or what do you like to cook? And this type of relationship really honors the patient's autonomy. And, for those of you who know me that have probably heard me say this before, but, I think in general, our folks in Wyoming we like our autonomy. And, it's important for us as clinicians to remember to honor that, that beautiful sense of autonomy. And I actually think of it as pride as well. So these are some guiding principles of motivational interviewing. The first one is resist the writing reflex. So we have this amazing, knowledge bank of, guidelines and what foods have less sodium and all of this, wonderful information that we've been gathering and learning for years. And sometimes it's appropriate to use it and sometimes it's not. So resisting the writing reflex is exactly that. So we really want to be mindful of how we're working with people, what we're saying to them. You know, it maybe or maybe not. You know, if it's something where patients in, you know, it's a patient safety issue, then of course we want to, you know, speak up and express the difference. But sometimes, you know, resisting the writing reflex is a little bit. It requires us to be a little bit more mindful of our communication with people. Understanding motivations, understanding what motivates a person by asking, and then of course listening. And I think that that's probably the key, is to really listen to our clients, ask them a question, and really try to understand them from their perspective. Also empowering people. I think this is a tool that I think is really important as well, is really getting people to think out loud. When they start to, when you ask somebody a question, and, you know, I would love to hear some of your experiences with this as well, but as people start thinking out loud, they start to find their own solutions. Tell me about your day. Tell me how you cook. What do you like to cook? And get people thinking out loud, because then sometimes they find their own answers in that process. And that's where we come into play as a guide, you know, knowing when to ask them more questions and when not to ask more questions as well. So I think I have a few more minutes to talk about SMART goals. So for those of you who use SMART goals, this is probably going to be a review. And if you don't use SMART goals, I'll just go over the basics. So SMART goals are specific, measurable, attainable, relevant, and time-based. And SMART goals, I guess the way that I think of SMART goals is it takes the goal, it takes it out of the category of a wish and puts it into a really practical way of achieving a goal. So let's see. Oh darn. So I wanted to talk about a couple of SMART goals. So a SMART goal could be something such as, you know, on Mondays, Wednesdays, and Fridays, I will walk with my friend Lucy for 45 minutes with our dogs. That's an example of a SMART goal. So it's specific. I will walk with my friend Lucy. It's measurable because you're, you know, Monday, Wednesday, and Friday. It's attainable, and that's something that you can really work with the client to determine. It's relevant, and it's time-based because it's, you know, Monday, Wednesday, and Friday. And then we always want to make sure that we're assessing people's goals when they're coming back to us. So tell me about your goals. You know, what's working? What challenges are you facing? And again, what's working? I love starting with a positive, because then we can, you know, oftentimes people come in and they just say, oh, nothing's working. My blood sugars are all out of range. And I'm just, you know, I didn't get to the store. But then sometimes I'll try to turn the situation around and say, well, what's working? What went well for you this week? And if they can't identify something, I push them a little bit further to say one thing. Just tell me one thing that went right about your week. And it's amazing how that can really change somebody's attitude. You know, also with assessing goals, you know, tell me how's your physical activity, or what are you doing for self-care? Tell me about your support system. Spend time. And I think this is another really great point, is really to ask people about, you know, what are their support systems? Many people don't think they have support systems, or are unable to identify a supportive person. Help them think through this step. And this can also be identifying organizations or things in the community that can be supportive as well. And I think that I keep messing this up. I think that is all I have. And I wanted to see if anyone has any questions.
Maureen, there was one put in the chat box.
Okay, I'm going to get back so I can see that. Great. Okay. So Pam, how do you educate patients on how to calculate 2,300 milligrams per day of sodium? That's a really good question. So it would start with, basically doing, for something like that, I would probably start doing a little bit of a diet recall with someone, so something like, tell me about what you eat on a daily basis. And if there are things that the person, if somebody says something like, oh, well, I go to Wendy's and I get whatever, that's something that you can actually look up and see how much sodium is in that food. But I would really make it really specific to that person, to really make it relevant as well. Does that answer your question?
Pam, I'm going to unmute you so you can talk.
Yeah.
I'm going to see if I can find you here and make it so you can.
My office number is
Yeah.
633-679.
Thank you, Brenda. Yeah, that helps some. It's just, when we tell patients, you should have this many carbs a day and you should have this many grams of fat a day. I think it's sometimes helpful. I know for me, what does that look like?
Mm-hmm.
And then how to try and figure out how many of those you had in a day. So even for the sodium, for example, I could look that up, but do you have them keep track then of
sometimes
the number of milligrams?
And just remember that 2,300 milligrams of sodium is one teaspoon. So that's a good visual to use. But also remember that most of the sodium that we're consuming, especially for people that are consuming high sodium diets, it's often not coming from the salt shaker. It's coming from packaged foods or prepared foods. And so for somebody like that, because you want to get them thinking about, sodium, I would have them look at a label, or bring in a label. Well, bring me in a label of, something that you eat on a regular basis, and let's look at that together.
Yeah, I think that's really important. We hear all the time you need to eat a healthy diet. Well, what does that really look like? And what I might think is a healthy diet really is not. I think referring to a dietitian is the most important thing.
Yeah, not all communities, or I hope that at this point all communities have a few dietitians, but sometimes there aren't in some of our rural communities. So really helping people look through that. And this is just me personally, but everybody's, there is no one perfect magic diet. A lot of the people that are writing books are going to want you to think that, but there's really not. So I always try to think about, one of the questions that I pose to patients often is, tell me one thing you could do to improve your diet.
I like that question. You mentioned the DASH diet. You're hearing a lot. I'm hearing a lot about the DASH diet now. What are your thoughts on the paleo diet for diabetics?
Well, so the paleo diet, from my understanding, really relies on a high protein. I don't think it's. I think it's I just think it's another marketing book.
Okay.
I personally, I like the DASH diet and the Mediterranean diet, because those are diets that have been research based for a while. I don't really know that much about the paleo craze, to be totally honest.
Okay, thanks.
I hope that wasn't a politician dodgy question answer.
No, it wasn't. Thank you.
Super. Well, we've got a little time left, folks. If you have a question, you can type it into the chat feature or raise your hand and I'll unmute you so you're able to talk directly with Maureen. So Maureen, I do have a question for you, and I probably just didn't catch it, but a few slides back when you're talking about the exercise, you made the reference about doing something every 30 minutes.
Mm-hmm.
Explain that to me again.
So that was a recommendation from, I believe, the American Diabetes Association, was to reduce sedentary behavior. So really break up sitting. So every 30 minutes, making sure that people are getting up and moving. And that can be also something as, you know, as simple as doing some exercises in your office. And, you know, whether it's a stretch or just, you know, just getting up and doing this, you know, I know that always feels really good to me, but just something to continue to move throughout the day. Because otherwise, what do? You know, we sit at our desks and we work all day long, and then before we know it, you know, 3 hours have gone by and we haven't moved.
Right, right. I think it's nice to put a time frame on that. I think that's a good suggestion.
Mm-hmm. And those are places where we can use technology if that's appealing. You know, some people choose to use technology, some people don't. It really just depends on, you know, how you feel about it. But, you know, you could set a little timer or do something simple to remind you to get up and move.
Right. Great. Great. Well, I don't see any other questions that has come in. Maureen, thank you so very much for joining us today and presenting this great information. I want to remind our attendees that if you want the CE for this session, be sure and return the evaluation that Maureen sent out earlier. And then we will send you a SurveyMonkey evaluation for us at the YPCA. We do appreciate your help in doing that. And I hope you'll join us for the last of our series, which will be December 27th at the same time from noon to 1. So look for that in your inboxes.
And feel free to email me if you have any additional questions.
Great, great. Thank you for that.
Thank you.
Bye-bye.
Bye.
I'm going to stop the recording.